Hi, and welcome to the VieSID Press-release. In this video, we report on articles selected from the dental literature published in February 2024 that we hope might be of interest to the VieSID community. So let's begin. From the AJODO, we selected an article by Sarvafta et al. Exploring longitudinal changes in adult face based on cephalometric data. They included 8 male and 8 female subjects from which cephalometric data and dental casts were collected at age 20, age 30, and age 50 approximately. The subjects included were both +1 and +2, but didn't have major skeletal deviations. The data collected included measurements on both the skeletal face and the soft tissues, maximum length and width at the level of the canine, first premolars and molars were collected from the upper and lower dental casts. Comparing the differences between T1 and T3, the authors reported a different sagittal and vertical growth of the midface, leading to a backward rotation of the mandible and a drop down of the nose and thinning of the lips. These changes seem to be more pronounced in females than males. Instead, differences in the dental cast measurements at the different times were not statistically significant. Longitudinal data is usually difficult to obtain, hence the value of this work. However, if morphological changes related to maturation of the face do occur, they should be tested probably with a larger sample. Also, the use of geometric morphometric techniques might help. Most importantly, the author should have tested for the intra-observer error to prove that the observed differences didn't originate from sampling inaccuracies, which are at high risk in cephalometric analysis. In the Annals of Anatomy, Candatil et al. Performed an anatomical study of perforators and corresponding perforasomes. The study is relevant for flap surgery, which is performed to cover skin and soft tissue defects, also in the area of head and neck. It is only in 2003 that the term perforator was defined in a consensus paper by Blondil et al. As a vessel that has its origin in one of the axial vessels of the body and that passes through certain structural elements of the body, besides interstitial connective tissue and fat, before reaching the subcutaneous fat layer. In this image, you can see different types of perforators. Instead, the term perforasome refers to a vascular territory perfused by single perforator vessels of a named artery. Since Doppler ultrasound is not applicable to distinguish perforator from source artery, anatomical studies are needed to identify perforator areas along the course of the facial artery. The authors dissected 20 facial arteries from 10 fresh anatomical head specimens. The perforators with an outer diameter of at least half a millimeter were identified and injected with dye to color their respective vascular territories. In total, 89 perforators were identified. The average number of perforators per facial artery was 4.5. The mean outer diameter of the perforator at the origin of the facial artery was 0.65 millimeters. Size and location of colored skin territories, as well as the location of its perforators, were documented and statistically analyzed, as in this schematic representation for one subject. This image instead represents the superimposition of the results for all subjects. The mean size of the color skin territories was 577 square millimeters, plus or minus 488 square millimeters, meaning that there was a high variation in the extension of the skin territories. Perforator diameters were significantly associated with the size of its resulting perforasomes. So this is the scatter plot showing the positive correlation between perforator diameter and perforosome size. Instead, this histogram illustrates the distribution of the distance from the lower border of the mandible to the perforators in the different specimens. Furthermore, perforator mostly originated from two specific areas. This heat map is based on the coordinates of the different perforators. The areas with higher frequency of perforators are identified by the darkest red colors. In particular, two hotspots for facial artery perforators were identified. The position of the center of these areas was measured from the anterior nasal spine. So hotspot A on the left side is at 3.5 centimeter to the side and 3.5 centimeter caudal to the nasal spine, while hotspot B is more laterally and caudally located. These outcomes should be taken into account by surgeons as well as clinicians injecting fillers or Botox. In the archives of oral biology, we found an article by Mutu et al. Providing primary tooth eruption chronology charts based on evidence retrieved from the literature. Dental eruption time in children is clinically relevant. Thus, the authors engaged in a meta-analysis of information retrieved online from electronic databases, gray literature, and through-hand searching for inception to April 2023, and eventually included 42 articles. From these articles, information was gathered for a total of over 42,000 children with an age range of 0 to 83 months. 22 articles reported results from Asian populations, 7 from Europeans, 5 for Africans, 4 for North Americans, 3 from Oceanians, and 1 for South Americans. The main outcomes of this study are shown in these diagrams. For the maxillary teeth on the left side and for the mandibular teeth on the right. Based on their outcomes, Mutu et al. Showed a high range of variation for primary dental eruption across the globe. Primary tooth emergence is reported to begin at 4 to 10 months after birth and to be completed by 30 months, according to Soliman et al. 2011. In this study, a range of 6 to 36 months was observed. The tooth emergence was very varied. For example, mandibular central incisor was the first tooth to erupt at 6 months in reported for North African populations, while the latest age was reported in Asia at 13.5 months. The mandibular second molar was the last to erupt at 20 months in Europe and 29 months in South America. Concerning maxillary teeth, Europe reported the earliest stage of eruption of the right central incisor at 8 months, while the left central incisor erupted only at 12 months. The second molar showed significant variation in the age of eruption between the continents, ranging from 21 months in Europe to 30 months in South America. A similar variation was observed for the lateral incisor, canine, and first molar in the maxillary and mandibular dentition. The mean age of eruption was earliest in the European population for all primary teeth, followed by North America, except for the maxillary, canine, and molars, where the Africans were ahead. On the other hand, South America, followed by Asia, recorded the latest ages of tooth eruption. Mutu colleagues reported on additional information. Factors such as sex and social economic status didn't seem to play a major role based on the available information. Instead, they detected a non-uniform dental eruption for the right and left sides of the jaws in different populations. Concerning Africa, significant differences in the mean age of eruption were observed in the mandibular lateral incisors of up to 1.4 months, With regards to Europe, clinical significant differences were observed for almost all teeth, ranging between 3 to 9 months. In South America and Oceania, the mean ages of eruption were consistent between the quadrants, while this information was not reported for North America and Asia. In Cranio, Sabato, Bundo et al. Performed a systematic review to evaluate the benefits of hyaluronic acid intraarticular injection in conjunction with minimally invasive surgery such as arthrocentesis or arthroscopy. TMD patients tend to present high levels of compressive stress in the joints with inflammation and decreased blood supply to the joint. So hyaluronic acid intraarticular injection is considered as a therapeutic option for temporomandibular joint disorders because it maintains lubrication, decreases mechanical wear, and prevents intraarticular fibrosis. The authors performed an electronic search in PubMed, Cochrane Library, Scopus databases to answer the following question. In clinical trials with patients treated with arthroscopy or arthrocentesis, did the subsequent use of hyaluronic acid intraarticular injection provide a better control of postoperative pain and temporomandibular joint function compared to those patients who did not receive it? Based on the PRISM criteria, 6 randomized controlled clinical trials were selected. The articles were varied in terms of number of patients that had to be at least 10 based on the selection criteria of the authors and reached a maximum of 62. Age varied between 15 and 64 years, and different TMD types were considered, including disc derangement with reduction or without reduction, or unspecific disc derangement. The treatment efficacy was evaluated through the VAS scale for subjective assessment of pain and maximum mouth opening. The JADA scale revealed that 4 studies presented low quality and 1 moderate quality and only 1 high quality. Based on the Cochrane tool, 3 articles were classified as high risk of bias, and the remaining 3 articles were considered to be moderate on account of a low or unclear risk of bias for all key domains. Obviously, the outcomes of these studies should be considered cautiously. So the outcomes showed some statistical significant outcomes for mouth opening or pain reduction when using intraarticular injection of hyaluronic acid in conjunction with arthrocentesis or arthroscopy, as underlined here. The authors concluded that despite the fact that this treatment approach is commonly used to reduce TMD symptoms, very few reports evaluate its actual efficacy. Additionally, studies are required to test the efficacy of intraarticular injection of hyaluronic acid in arthrocentesis and arthroscopy. In Edenface Medicine, Zhang et al. Published an article in which they tested the effects of twin block appliance and the clear functional aligners on the TMJ in adolescent patients with class 2 division 1 skeletal pattern. Patients were selected based on a detailed list of inclusion and exclusion criteria. Patients were treated with clear functional aligners and 24 with twin block appliance. In each of the groups, males and females were equally distributed. Patients were approximately 11 years old at the beginning of the treatment and were treated for about 12 months. The evaluation was performed by collecting linear distances on the CBCT from the TMJ to assess possible changes in intrajoint space and from the mandible to assess mandibular and condyle growth. Additionally, condylar volume was computed after visually the outcomes of the t-test analysis performed show no differences between right and left sides within the 2 groups. Post-treatment statistical differences were detected for both experimental groups for most of the same parameters except for one that was determined only for the functional aligner groups. Although the authors seem to show a positive outcome of the treatment consisting in mandibular growth, the study does not consider a control group, and therefore we cannot rule out that the differences observed in the study between before and after treatments are attributable to mere growth. What about the comparison between the two treatment types? When comparing the twin blocks versus clear aligned groups after a treatment, three parameters differ significantly. An increased anteroposterior mediolateral growth of the condyle in the twin block group was observed. A greater increase in condyle height in the liner groups, that is in red in the image, was recorded. And the reported histograms greater increase in mandibular ramus length in the twin block groups, which is in blue. I find these results a bit puzzling because the length of the mandibular ramus includes the condylar height. So these results seem contradicting. Thus, I wonder whether the identification of the plane set to divide condyle from ramus was standardized. Anyway, I'm afraid that based on this study design limitation, this work cannot be used as evidence for the clinical outcomes of mandibular repositioning by twin blocks or clear liners. We have come to the end of this presentation. I invite you to contact us in case you want to know more about our activities. So otherwise, be ready for next press release. Best wishes to all.